Maintaining universal immunization programs requires an immense logistical apparatus designed to preserve cold chain antigen delivery from the manufacturer to the clinic. This is the 2025 CDC Recommended Child Immunization Schedule. It serves as the clinical gold standard for plotting the precise timing and intervals of pediatric doses. The clinical assumption baked into this matrix is straightforward. Adhere to these specific intervals, deliver the antigen safely, and the population achieves uniform seroprotection. But empirical data breaks that assumption. In vulnerable and resource-limited pediatric populations, 10 to 25% of patients fail to achieve seroconversion after receiving these exact doses. Flawless logistical delivery of an antigen does not guarantee biological immunity. The current clinical focus is fixated on the quality and timing of the vaccine itself, often overlooking the biological state of the patient receiving it. A vaccine is not a finished shield.
It is a biological stimulus, a set of instructions that demands an active, resource-intensive response from the host. To successfully manufacture an antibody response, the host's immune system requires specific biochemical raw materials. 4 exact micronutrients act as the rate-limiting factors in this assembly line: vitamin A, vitamin D, zinc, and iron. A host's baseline micronutrient status, not just the timing on the schedule, effectively regulates the resulting level of vaccine efficacy. Look closely at the CDC schedule, and you will notice the heaviest concentration of primary and booster vaccinations falls squarely within the 12 to 24-month window. Exactly at 12 months, a toddler's physiology shifts. Growth slows, causing a natural drop in caloric requirements to roughly 1,000 to 1,400 calories, often accompanied by the onset of picky eating. Simultaneously, many parents transition their children away from iron-fortified infant formulas and breast milk, introducing whole cow's milk as a primary beverage. This diagram of the intestinal lining illustrates the mechanical interaction at play. Consuming high volumes of cow's milk, anything over 16 to 24 ounces a day, actively inhibits the body's ability to absorb iron. Furthermore, excessive milk proteins can irritate the intestinal mucosa, leading to a gradual loss of existing iron through microbleeding. These standard pediatric dietary transitions create the exact micronutrient deficiencies that blunt immune capacity, occurring precisely during the most demanding phase of the immunization schedule. Down at the cellular level, we can observe how these specific dietary deficits stall the immune response when an antigen is presented. Iron acts as a critical catalyst. It drives the rapid multiplication of lymphocytes and fuels the oxidative burst activity in neutrophils required to clear pathogens. Zinc is critical for synthesizing new DNA and executing cell-mediated immunity through T-cell activation. Vitamin A maintains the structural integrity of epithelial barriers and powers the mucosal immune system, and vitamin D modulates the innate immune response, operating like a volume dial for cytokine production to prevent the system from underreacting. A deficit in any of these pathways produces a specific failure. Missing iron attenuates the response to pneumococcal vaccines, while low zinc specifically impairs hepatitis B seroprotection. Without these 4 reagents, the manufacturing line for antibodies is compromised, leading to these suboptimal responses observed when the CDC schedule is applied to a deficient host. To isolate and test this variable in a real-world pediatric setting, researchers conducted a prospective cohort study published in the European Journal of Cardiovascular Medicine. The trial tracked 300 healthy children, aged 6 months to 5 years, who were scheduled for their routine immunizations. This matrix visualizes their baseline health status. Before receiving a single shot, over 40% of these children presented with at least 1 micronutrient deficiency, and nearly 30% were underweight. Half of these patients served as the control group. They received standard vaccines through the Universal Immunization Program with 0 additional nutritional intervention. The other half formed the intervention group. They received the exact same vaccines, but were also given daily supplements of vitamin A, D, zinc, and iron, starting 4 weeks prior to the injection and continuing for 2 weeks after. Clinicians then drew blood at 4 to 6 weeks post-vaccination, using ELISA testing to measure specific antibody titers for DTP, MMR, hepatitis B, and pneumococcal vaccines. This design set up a direct test comparing the results of mere logistical timing against verified biological capacity. The blood work revealed a stark contrast in post-vaccination seroconversion between the two cohorts. This chart shows the failure rate in the standard care control group. For the MMR vaccine, only 72% of the children achieved seroprotection. For the intervention group, the numbers surged. Hepatitis B seroconversion jumped from 79 to 95%, and MMR leaped to 91%. The quantitative data confirms the impact. Mean post-vaccination antibody titers were 30 to 40% higher across the board for the supplemented children. Subsequent regression analysis mathematically confirmed that baseline levels of vitamin A and zinc were the strongest positive predictors of an optimal vaccine response. Correcting these nutritional deficits prior to injection is a highly effective, quantifiable adjuvant to the immunization schedule. Applying this data requires a structural shift in the daily workflow of clinical pediatricians and public health strategists. This visualizes the CDC schedule adjusted for reality. It integrates a nutritional screening checkpoint as a preceding step before the timeline bars begin. Integrating this screening provides the biological foundation needed for the administered doses to reach their full immunogenic potential. In high-risk or resource-limited settings, delivering an antigen without first securing the host's iron and zinc levels is a clinical gamble. Administering a vaccine without verifying the host's biochemical capacity leaves a preventable gap in preventative medicine. Zooming out from individual patient care, this data redefines how we approach our broader epidemiological goals. Historically, public health initiatives have measured success strictly by the sheer volume of doses delivered and the logistics fulfilled. But true herd immunity requires a high percentage of actual seroprotection, which relies entirely on the biological capability of the population. The future of public health requires moving beyond simply delivering the antigen on time. We must ensure the host is fully equipped to process it.